You'll be going live in the next 5 seconds.
Okay. Hello there, and welcome to this session. My name's Gareth Collier. I'm a chest physician in Hywel University Health Board, and I'll explain where that is in a moment. I've got an interest in lung cancer, and also have had an interest in looking at the various data collection and audits and outcome measures to help shape our service. So I'm hoping that over the next half an hour I'll be able to give you an idea of what we've done and the direction that we're planning to travel in. If we could have the next slide, please. Just some acknowledgements. There's been a huge effort in this area, both from within the health board, and we'll talk about that later, but also the value-based healthcare programme within Wales that started off with the PROMs and PREMs team, and NWIS, our Welsh informatics service as well, have been instrumental in helping us with the various streams of this project, various arms of this project. So a big thank you for that, and I want to acknowledge everybody. Could we have the next slide, please? So I just wanted to a brief outline really, and spend some time describing the background of lung cancer and the setting that we're in, and then also moving on to how we started using data initially and the problems that identified, and identifying a need for greater feedback of our data with regards to how our patients were progressing, and what treatments they were having and their outcomes that they were getting. And that led to a vision which we'll describe, and then I'd like to show you a little of what we've managed to achieve, and then a little bit about where we'd need to go, and then some time for questions at the end. So next slide, please. Where is Hywel? Well, you can see the pin of London and then Cardiff, and if you keep heading west, Hywel is right at the end of Wales. Next slide. We can see there then, so the tan area outlines Hywel, right on the western edge of Wales, but actually covers quite a large landmass, so about a quarter of the landmass of Wales, but our population is relatively small, 350,000, 40% living within the rural area. That's actually, and as we're seeing, is most of our population was socially distancing even before that became a necessity, and so for COVID, that's quite a good thing. But in terms of delivering services for lung cancer, the rural spread of the population is actually quite a challenge. And to put this into perspective, in Hywel, we get about 300 cases of lung cancer per year. Wales as a whole gets about 2,200, and across the UK that's about 37,000 cases of lung cancer a year. So just to give a perspective on that. So next slide, please. So one of the joys of living on the western edge of Wales is, and I'll introduce it through, we live in an amazing environment, and with beautiful coastline and beaches. And if I can attract any of you to come and live and work in West Wales, then I hope to do that. So next slide, please. So at the beginning, really this started for me certainly in around 2005, when the National Lung Cancer Audit was set up. This is a UK-wide audit, and it began collecting data on all lung cancer patients throughout the UK. It was commissioned by HQIP and run by the Royal College, and it started slowly and published every year, and was collecting lots of parameters, and has got steadily better and better as they've increased their sort of collection methods, and people have really bought into it. So the lung cancer community, in terms of clinicians, really bought into the audit and were looking at the published data to see how they could improve. And it was one of the first national audits to really demonstrate that by publishing the data yearly, you could improve the quality of the data, because people were looking and obviously didn't want to be seen as outliers, and therefore if your data was suspect, then you needed to improve your data. But also it was able to show that we were able to demonstrate improvements in quality of care. So histological confirmation rates rose, surgical resection rates rose. The significance of that, of course, is that surgical resection rate is linked to survival. And so we've seen a steady increase in that across the UK. Next slide, please. So this is an example, and if you're anything like me, you'll be trying to peer at and pick out details, and this is an example of what the data would look like when it was published, with a few key messages at the beginning. And the data's published, it was often a year behind, so that the 2014 cohort would be published in about 2015-16. So you would have to look through the data. You would pick out your relevant spot, and you know, there were lots of different parameters that were being looked at. These were predominantly process parameters. So you know, how many patients had a bronchoscopy, how many patients had a biopsy, how many patients had an anti-cancer treatment or surgery or radiotherapy. They were all things around the process that the patient had been through. Again, you would have this, and then you'd have to go back to your back copies to see whether you'd really improved that year and what other people had done. So although it was a big step in the right direction, it was relatively cumbersome to actually track how you were doing year to year, and it was very it was delayed, so it wasn't current. So there was a temptation to say, well, okay, this data is now 2 years out of date, we've changed our service, let's see what happens next year. So next slide, please. So what you could do, and this is my very Heath Robinson attempt, is you would take the data over the years and start to track it and see how you were performing. And again, these are early attempts at trying to make the data meaningful and answer questions that are relevant to what is going on within your own service, and comparing that across the national national data. Again, it's just an example. Next slide, please. And if you can click. So these slides, the audit, in fairness, recognise the difficulty of looking at this data and started to collect it and present year-on-year changes, and those two histograms really showing that there was a demonstrable improvement over time in people giving chemotherapy to patients, people getting a better histological diagnosis of their lung cancer. This just publishing data, showing where people were, allowing people to identify if their practice was an outlier, was clearly demonstrating that people would look at that and respond to it and improve their practice. Next slide, please. As I mentioned before, most of the data were kind of pathway process measures being collected. We had very little in the way of actual outcomes, other than survival, which of course would be one of the most important outcome measures in lung cancer. This is particularly important for Wales and really the UK, because many international studies were suggesting that actually our survival for lung cancer, and this is 5-year survival of lung cancer in Wales, shows that compared to the rest of Europe and internationally across the world, that our survival rates are behind that of comparable countries. And so there was a lot of work that needs to be done in terms of trying to improve that, but also understand why that might be. Next slide, please. If you click again, hopefully a circle will come up. Yeah. So what the way this would work is that you would see published data, and this is data on radiotherapy, percentage of people having radiotherapy for non-small cell lung cancer, and you would identify outliers, and you would identify where you were, and then within the Welsh Cancer Network and with the audit themselves, if identified as an outlier, you'd be challenged to explain it. And I want you to sort of focus here on the second circle, Ceredigion and Mid Wales. Now that relates to ourselves here and Bronglais. And we see that in comparison to some of our colleagues who we were giving relatively low amounts of radiotherapy. Now, when you look at that data, you could think, well, gosh, what's happening here? You're almost twice as likely to get radiotherapy in one area as opposed to another. If we go on to the next slide, and we'll talk a bit more. So this was the UK data across the same time spot, and what we see, we've got the median. And if you remember then that Ceredigion and Aberystwyth actually was in the sort of middle quartile, and was very, very rarely in the lower quartile, so it wasn't really an outlier. We were just comparing the very top of Wales against perhaps the lower. And what really is interesting and raises really interesting questions here is that obviously radiotherapy can be used for palliation of symptoms as well as for radical treatment. And what that data didn't tell us was what proportion of patients at each centre was getting radical treatment with curative intent, and what proportion were having a fraction of radiotherapy designed to treat their cough, pain, breathlessness, coughing up blood, etc. And when you look further, Ceredigion and Bronglais is about a 2.5 to 3 hour journey from the nearest radiotherapy centre. So if you've got a patient and they have a cough or they have some pain, perhaps radiotherapy isn't the first modality that you would think about giving them. You might persevere with other treatments. Of course, and again, what crucially, this data doesn't tell you the success, the outcome. And I think that this really triggered an interest in trying to look at outcome measures that really matter to patients, because ultimately that's the most important thing, and would then allow us to shape our services across the Wales to deliver the best treatment for those patients. Next slide, please. So the realization that we needed to get more sophisticated in our audit and our data measurement also coincided with the introduction of ICHOM and their work on looking at an international set of standards, audit standards, as well as outcome measurements. And so we were able to look at an international group that were thinking along the same lines. So that stimulated us in Wales to start thinking down this route. So next slide. As promised, that's a midsummer's morning over the Towy Valley, a stunning location there. So next slide, please. So this realization that we needed to become more sophisticated really started to think about, well, what would we actually require? In a perfect world, what would we have? And so clearly a standardized data set that could be compared not just across Wales, but across the UK and ideally internationally. That there was a focus on outcome measures that were important to patients, not just process measures. Again, the previous discussion, does it matter how much radiotherapy you give if the patient has the same outcome? So again, wanting to have that standardized data set to allow comparison between national and international centres, and in a time frame that is relevant. There's a real difficulty that if this data has to be refined, it has to be accurate, it has to be trusted by the clinical teams. But if it's a year out of date or 2 years out of date, the chances is the service has changed slightly and it makes it difficult to know if it's relevant anymore. Ideally, clinicians and clinical teams would have access to their own data and in a sort of a dashboard view, so that they could tailor it to look at the particular parameters that they were or interested in and felt were appropriate for their patients. That it would allow us to link up outcomes with pathway data, again, waiting times for different procedures. And the data, the types of data we're collecting needed to be clinically relevant to the teams on the ground, so that they were invested in ensuring that it was accurate and they believed it. So next slide, please. So we were fortunate in Hywel to have a team that wanted to take this sort of work on, and we set up a pilot project, and Gareth Davis was instrumental in helping us really liaise and get the informatics and the understanding right, and I'll talk about that now in terms of the outcome data. So next slide. There's often it's very fortuitous that there are a lot of different developments going on at the same time. So this was all being worked along with a very much a Welsh national thrust to be looking at patient outcomes and experience measures. This coincided with work in the informatics service to set up data warehouses where we could collate all the data from across Wales from multiple different data sources and really make those available in consultations to clinicians and in planning meetings to the multidisciplinary teams. So this idea that the patient might be contacted, be able to complete questionnaires at home, that's available then and available in consultation and can be available across the patient journey. So next slide, please. Now this, in order to look at outcome measures and be able to have them comparable across international settings, ideally you have a standardized questionnaire that's been proven to have clinical relevance and meaning in that particular disease setting. So the European Organisation for Research and Treatment of Cancer has a questionnaire, the C30 questionnaire, and also then disease specific, so LC13 for lung cancer specific. And as Gareth has outlined here, it's 30 questions, a number of functional scales, symptom scales. Now, as a clinician, I was used to dealing with the St. George's Respiratory Questionnaire, again, a well-proven questionnaire looking at sort of quality of life in patients with COPD, and that was a simple score, and we knew that a 4-point change in that score was clinically relevant, and that had been proven over time. If we go on to the next slide, what Gareth was able to help us understand really quickly was that the EORCT score didn't follow that pattern. The symptom scores and the questions weren't structured linearly. So some scores had 3 points to it, some had 4, and that made looking at it in a simple numerical way quite difficult. Next slide, please. I'm running out of time. And this is what Gareth is illustrating here. If you're going to try and convert this into a numeric score, it's going to be quite difficult to see what's going on, and different changes, different questions makes it a challenge for that. Next slide, please. And if we skip this slide, what we were able to do with NWIS and with Gareth and the clinical team is start to develop dashboard views that you could open up when you were seeing the patient. The patient would fill in on an iPad in the waiting room, and that's why we needed the support of the outpatient team. And actually patients found it quite easy to do. We had far less problems than we thought we would encounter. And we started to produce these dashboards, and if we go on to the next slide, they look initially quite complex. So this is an example that I could see in clinic of a patient coming across 4 different consultations, and what Gareth devised is these coloured boxes to sort of show change across consultation, but also to show scores that were of indicating perhaps a significant problem. So if you click again, as I said, this looks quite complex, but the team with NWIS and Gareth were able to have it so that if you hovered over these little spyglass icons, you would get a little explanation of what that score meant in terms of the physical function scale, whether it was a good score or a bad score, and then subsequently you could see arrows were added to show whether that score was changing over time. If we click on for the next slide again, and again. Again, if there were single items, you could click and again, and it would give you an idea of what the questions were, and then what the answers were to those questions. So although it looks complex, there was quite a lot of feedback built in. Next slide, please. This is again another view of Carrick-Kennin Castle, again in the Towie Valley. So next slide, please. Again, Gareth we were experimenting with different views, trying to find out what would be useful clinically. So again, this gives you the opportunity to see baseline functioning and follow up. Again, the blue dot would show that this was that was the actual patient score, and again, yellow being all the patients in the same cohort that scored worse, green showing all those patients that scored higher values and how that might change over time. Next slide, please. And again, some pop-up boxes available. Next slide. And next slide again. I'll skip because I'm sorry about this, but we're going through quite quickly. Again, similar sort of thing for just if you wanted to look at just the lung cancer scoring. Again, we're seeing patients presenting with dyspnea and cough, then going on to have treatment and seeing an improvement in those scores. So that's quite a useful view, I think. Next slide, please. Next slide, yeah. Okay, next slide. So what Gareth talks about here is that as opposed to what I was used to, and again with other scores, is that we didn't have thresholds for meaningful change. and that has now come in, and we've adapted that data dashboard to show a different color when there's been a meaningful change in score. Next slide. Now, I'm very conscious I'm running out of time, and there's been some questions. This is Tembe, a beautiful pot. I'm just going to quickly go through this. So there's another aspect to the dashboard, and a slightly separate dashboard. Next slide. Next slide. What we wanted to do is to try and bring together data from the National Lung Cancer Audit and our own CANISC cancer data record and various other databases into a view that would be helpful for clinicians. Next slide. Next slide. And next slide we'll go to. So this dashboard was built up within NWIS and was allowing us to look at across Wales, across the different organisations within Wales, and it would allow you to select for year of interest, health board of interest, and drill down as you can with many of these sort of dashboard tools. Next slide. And the data was linked so that you could actually look at your different pages and start to, again, as I say, look at disease areas. So if we click, we should see a pop-up button, yeah, come up. So if you wanted to look at those patients going through the emergency department, you could. If we go on to the next slide. Again, looking at different years, does that change from 2017 to 2018? Again, next slide. If you wanted to look at a particular stage, you can click on the blue bar, and then it actually alters the rest of the views to take into account of that. So it allows a user and a clinician to start to look at the data and ask questions that they feel are relevant about what's happening with their patient cohort. So next slide, please. Again, different views, so you could do that by geographic view and by GP cluster. Next slide. And again. So, not just beaches and mountains and castles, but we have lovely delicatessens and streets and lovely pretty towns. So there's lots for everybody in Hywel. So next slide, please. Again, just more examples. If we just click, I think there's some annotation there. Okay, so we wanted to bring in pathway data. You're able to isolate and look at time from referral to CT scan, time to diagnosis, bronchoscopy, MDT, and time to treatment. And if you click on those bars, you can isolate that then for your own specific health board to see whether you're better than average or worse than average. Next slide, please. Again, we started to try and look at how we might visualize outcome measures here, the EQ5D, and how that might show differences between different services, different areas. Again, this is work in progress, really. So next slide. And again, another view. Next slide. This was particularly what we wanted to do is in terms of data quality, at the moment we tend to have an Excel sheet and we're able to go through it and look and say where's the gaps, what bits haven't we filled in, and that's a bit of data validation. But what we wanted to do is recognize, perhaps our resection rate looks low for the last 6 months. We ought to do more digging into this, and you're able to click on this slide and on various aspects of it, and it will give you the NHS numbers of those patients. So it's actually a great tool to be able to start your audit and validate data much easier than we've had in the past. Next slide, please. And next slide. So I'm conscious that I've raced through a lot of that, but I really wanted to show that we've made a significant start in the way that we collect in patient outcome measures directly from patients in clinic setting and at home. And that's going to be increasingly exciting, I think, bearing in mind that COVID is changing the way we deliver services, and it'll be useful to be able to have pre and post COVID outcome measures that we can look to see, has our change in service made any difference. We are starting to look at how we combine different data sets and display that to the clinical teams in real time at the clinic setting. And really, I wanted to this has been an ongoing process, and there's a huge need in this process. It's not a fire and forget. It's not a project that you can say, right, this is 3 months and it stops. You have to have a commitment to this, that this is going to go and it's going to take time. You're going to give clinicians a tool to play with, and they're going to come back and say, yeah, it's okay, but we'd like it to do something different, or we've tried that and it's not working for us. We want to see it in a different way. And that takes time and effort and patience and investment that needs to continue over time. So I think that I've obviously gone over time. I'm sorry about that. The next slide, I think, finishes there. With just a view of one of our beautiful rivers over lockdown, really, and we were all exploring our local environment much more than we might have done previously. And so I'll finish there, and if there is any questions, I'd be happy to take those. So Sarah sent me through some questions. So there's in terms of, so there's a question here about the PROM tool being quite long and patients finding it onerous to complete, and certainly we were worried about that to start with, but actually patients seemed to adapt to it very, very quickly and needed very little input or help from our clinic staff. We found in the end it seemed to work quite well, and the advantage of pre-COVID, of course, was patients, you had a captive audience, so they didn't have an awful lot else to do, and so they were happy to fill in those forms. So we didn't find that problem, really. I have another question, which is the dashboard used for MDTs? So the outcome measures, not yet. Very much the views that we were showing were designed to be used in clinic to help with that patient consultation. I think there's a lot more work to be done around collating that data and using it to answer questions like we talked about in the beginning about, well, does one area having more radiotherapy than another for perhaps very practical reasons make any difference to that patient? And I think there's a lot more work to be done academically around that, but we've got to collect that information. We've got to have the PROMs in our system to begin with before you can start to really look at that data and see and understand what it's showing you. So it's not used for comparing MDTs and treatments at this stage, but that's very much where we would like to get to. But as I said, this is an ongoing process. Yeah, so there's another question, which is do we have information from health boards across Wales to drive the improvement? And this is the where I think we need the leadership and we need the commitment, and we need to accept that there will be people who will take this forward, and we need to invest in that, show the information, display it, and then I think people come on board when you show how valuable it is. It's that feedback loop. At the moment, the slides that I was showing you Again, we've used slides because in the live environment things are quite can be slow when we're doing it via a video link, but it's designed to be used in the clinic setting. There's a lot of data, and it's a clinical process, and it's a process of trial and error to find out what works, and so we need a few enthusiasts, in a sense, well supported, to really drive it forward and find out what works to roll out to other people, and so they can learn from our experience. So there's a few other questions. Yeah, so how do you adapt the needs of on the dashboards to different teams and clinicians? How do you motivate clinicians to report data and ask the patients to fill out PROMs? So adapting needs. So the second dashboard I showed you is very adaptable. It uses Power BI. So there is ability to modify and adapt and change and ask different questions. The PROMs dashboard isn't adaptable on an individual basis at the moment, but again, it's very much, I think that is the future and where we'd like to go. I think in terms of motivation, clinical teams, I think the National Lung Cancer Audit showed the way for that, and that is at various meetings at either regional, national in terms of Wales or UK level, you start publishing that data, you start showing people and ranking organisations, and as clinicians and as organisations you start to look to say, oh, we're not doing so as well as we thought on that area, and oh, the next health board down the road, they're doing really well. Well, let's share practice here. What are they doing differently? How do we improve? And I think it's embedding data and the use of it into clinical practice, so that, you know, as you start up your computer, instead of maybe getting the BBC News website as your homepage, you've got a data display of, well, what's happening with your lung cancer patients or your heart failure patients. You know, what's the service looking like? Have we had a rush of referrals? Are we getting the outcomes that we're expecting? And that's the future. That's the vision. We're not there yet. We've got some way to go. But as I said, that's the commitment, to keep on making this a continuous process of improvement, and it's the investment in that to make that process evolve over time. And yes, there's a comment that says, I think patients won't mind as long as they feel the data is relevant and being used, and absolutely. And I think that, you know, you can get to the situation where you can, we're used to reviewing the patient's results, and actually this questionnaire and feedback, a quick review, gives you an idea of what the patient might be experiencing, what their concerns are before they come into clinic. And it's also a way of, you know, patients often have things they want addressing, and then you give them a bit of news, a result that they're not expecting, and it kind of completely derails the consultation to where, you know, from the issues that they wanted addressing before they came in. And so having this information ahead of the consultation kind of gives you that ability to go back and say, oh, look, you know, is there anything else? And you did flag up that you're coughing more, or you've got more pain, or, you know, and so it can be used as a tool to sort of ensure that you start to address all the issues that the patients had. I'm very aware I've gone well over time, but I think I've addressed all the questions. So I'd like to finish just to remind you that this is an ongoing program throughout the week, and there are other sessions that you're welcome to join at the website. So thank you very much.